So let's talk about the HIV-exposed infant. And here as well, there are a couple of changes. So we said in terms of the postpartum period, to prevent transmission, we need a mother who's virally suppressed. That's our first prize. A second prize is that we also give infant prophylaxis if the mother is not virally suppressed. And if all fails, which we know that we can't fail, is that the HIV positive infant needs to be diagnosed as early as possible and started on treatment. And it's also about child survival, because we can't promote HIV survival on its own. It's HIV-free survival, which is why there's the promotion of breastfeeding. So let's talk about the principles of giving infant prophylaxis. So again, as the comment came through here, the ideal will be at the time of delivery, you already have that viral load. But unfortunately, we won't have that viral, because currently we're not doing rapid viral loads, okay? If you do have a viral load in the last 12 weeks that is suppressed, you categorize the child, infant, as low risk. So if you have a mother's viral load that was done during pregnancy, and by the time she gets to delivery, it was within a 12-week period, and in that 12-week period, that viral load, she was suppressed. She's we'll classify the infant as low risk, meaning that the infant will get low risk prophylaxis, okay? If you don't have that result, or the viral load was not suppressed, and in these cases, we're using a threshold of 1,000, because remember I said again that low-grade viremia is a concern, but treatment failure, it's still a viral load of more than 1,000. So we're saying here, if you don't have a viral load in the next 12 weeks, or the viral load that you have in the past 12 weeks was more than 1,000, you treat that infant as high risk. Yeah? And what does that mean? So our low risk, we're still giving 6 weeks of daily nevirapine syrup. And the high risk now is saying you give nevirapine syrup for a minimum of 12 weeks and AZT for 6 weeks. And what is the important thing about this extended nevirapine syrup? And for people who've been in the program long enough, remember in the 2008-9 guidelines, we're using extended infant prophylaxis for breastfeeding, okay? So what is the important thing about extended nevirapine prophylaxis for the baby? It's the dosing, okay? Because remember, you need to increase the dosing as the baby grows. Remember, we had those cards for people who've worked in Gauteng. We had those cards that they had the different dosages depending on the infant's age. So it's something, again, that we need to have. I don't know if it's in the guidelines, I haven't seen it, but the dosing chart for nevirapine as the infant grows older. Because what the guideline is saying about the high-risk infant is that as long as the woman's viral load is above 1,000, you continue with nevirapine. And this is a breastfeeding woman. Low-risk prophylaxis, regardless of infant feeding option, and mother's viral load at delivery is less than 1,000. That's a low-risk baby who gets 6 weeks of nevirapine. Yeah, clear? Yes. Okay. And then the next step is high-risk prophylaxis in the breastfeeding woman. So this is a maternal viral load that's more than 1,000 at delivery, or there was no viral load in the past 12 weeks before delivery that was less than 1,000. Or the mother was newly diagnosed or known positive but not on treatment. Then this baby will get a minimum of nevirapine for 12 weeks. And the nevirapine will only be stopped once you get a viral load of less than 1,000. And in combination with that, you will give AZT for 6 weeks. And then let's do the last block. The last block is saying this is a high-risk mother, but she's formula feeding, meaning that there's no HIV exposure beyond delivery. So she'll still get 6 weeks, she is the infant, or he, will get 6 weeks of nevirapine syrup as a standard, okay? And let's see here, it says mother on ART, viral load more than 1,000, or no viral load available, mother not on ART at the time of delivery. They will get high-risk prophylaxis for 6 weeks, meaning they get both nevirapine and AZT for 6 weeks. But if the mother is breastfeeding, minimum of 12 weeks of nevirapine, extend until the viral load is less than 1,000. So getting into breastfeeding, I know we've said a lot again. Don't forget the HIV negative woman, okay? Because all our efforts seem to be on the positive woman. But the negative woman is just as important. So it's keeping that HIV negative woman negative. And how often did we say we're retesting during breastfeeding?
6 months.
I see 3 on the left, 6 on the right.
6 months you said.
No, I didn't.
That's what you said.
I said 3 months. Okay? I said, remember, even in the old guidelines, it was 3 monthly. Okay? What has changed now is the 6 weeks. Okay? Now it's 10 weeks. But the 3 monthly still stays. Okay? The 6 monthly is viral load. Yeah, 6 monthly is viral load. HIV test for the negative is 3 monthly. Yeah. Yeah. No, viral load is 6 months. Okay. Okay. Oh, it's showing today. So there's the breastfeeding plus, and the breastfeeding plus is saying breastfeeding should continue for 2 years and beyond. Okay. And it's talking about how do you keep the negative woman negative, HIV risk reduction that we often forget about, partners, condom use, partner testing. If the partner is on ART, make sure that they're virally suppressed because they can still infect the partner. We know the risk of acquiring HIV is higher during pregnancy and breastfeeding, so they need to use barrier contraception. Partner needs to be virally suppressed. And the question of PrEP as well. Again, I'm going to refer to Matilda. I know the PrEP guidelines are under review. Is there anything in the PrEP guidelines for provision for pregnant and breastfeeding women?
I really don't want to commit or even say anything about PrEP until we have clear guidance.
Okay. So the answer is that there's no clear guidance yet. But then there's a risk assessment as well. Okay, let's leave PrEP for now until we have the guideline, the clear guidance. So the safe thing to say is that if the partner is positive, partner must be on treatment, partner must be virally suppressed. They should be using condoms. Okay, and we've talked about the HIV positive woman that she needs to be adherent to treatment. She needs to be suppressed. Is Julia saying something different? Matilda is saying no. Okay. And then obviously your safe infant feeding practices as well. And remember, the same guidance still applies about breastfeeding. I know we haven't included here exclusive breastfeeding. We don't need to spell it out, that the first 6 months are still about exclusive breastfeeding. So the things that we haven't mentioned, they still apply. Okay. Again, just to reiterate that the first prize is maternal viral suppression. Again, it's the reason it's first prize because it's easier than dosing nevirapine and extending nevirapine and remembering to be increasing the dose of that growing infant. So that is our first prize, is that HIV positive woman must be virally suppressed. And if the mother is not virally suppressed, part of the ABC and DNE is to say, why is she not virally suppressed? She could be a newly diagnosed, newly initiated on treatment. She could have, we've talked about the risk of resistance, and we're giving the high-risk prophylaxis until she re-suppresses. Let's talk about infant testing because there's been a couple of changes as well, okay? Birth PCR still remains, and it's one of the things that's been done very well, okay? And then 10-week PCR still remains as well, and we are aligning it with the mother, okay? 18 weeks has been removed. There's now a 6-month PCR for the baby, and it's aligned with the 6-month viral load for the mother. Okay, so at the 6-month visit, baby gets PCR, mother gets a viral load. Okay. And it's likely for the negative mother, that would be the timing to repeat her HIV test as well, because we're doing it 3 monthly. Okay? And then the other new thing is that there's universal testing for all children, HIV exposed and unexposed. So at 18 months, all infants get an HIV test. Okay? And what has changed is that, we'll talk about this now, is that what do you use as confirmation at the different stages of diagnosis? And it doesn't mean that we have that schedule. If the child is symptomatic, you test the child. Okay? And 6 weeks post-cessation of breastfeeding, regardless of what is the timing of breastfeeding, you need to do an age-appropriate HIV test. Okay? And the new thing at the bottom there is that, remember we were saying we're using a confirmatory antigen test up to what age previously? 18 months. Now it's been increased to 2 years because it's been shown that maternal antibodies can still persist up to 2 years. So if you've got a positive rapid test in an infant up to 2 years of age or a child up to 2 years of age, you still need to use an antigen as a confirmatory test. Okay? And this slide just summarizes that less than 18 months, you do a PCR, you confirm with another antigen test. 18 months to 2 years, you still need an antigen test for confirmation. Beyond that, you do an antibody test, you confirm with another antibody test. So beyond 2 years, you do what you do with the adults. What that block is saying, what I was saying earlier, is that it's been shown that up to 2 years of age, the infant can retain maternal antibodies and test positive on an antibody test, which will be a falsely positive test in a negative baby. Okay? That's what the block is saying. Okay? And then this is where the importance of breastfeeding comes in again, is that more and more research is showing that the HIV-exposed but uninfected infant is also at high risk of all sorts of things, which is why we're talking about HIV-free survival, is that the babies that are HIV-exposed are at increased risk of poor outcomes, neurodevelopmental issues, anemia, hospitalization, and all sorts of complications. So they are just as important as the baby who ends up being HIV positive. Okay. So a successful program equals an HIV negative baby who's thriving, normal growth and development.